Dear colleagues, my name is Laurelle van Tilburg and I'm a PhD candidate at the Department of Gastroenterology and Hepatology in the Erasmus Medical Center in Rotterdam, the Netherlands. On behalf of the co-authors, I would like to thank Endoscopy for this opportunity to discuss our paper titled Endoscopic Screening of the Upper Gastrointestinal Tract for Second Primary Tumors in Patients with Head and Neck Cancer in a Western country. Patients with head and neck cancer relatively frequently develop second primary tumors. This is often explained by the theory of field cancerization. This theory states that premalignant changes of the epithelium surrounding the primary tumor can occur and are caused by long-term exposure to common carcinogens such as tobacco smoke and alcohol consumption. And these second primary tumors are often located in the upper aerodigestive tract, which consists of the head and neck region, lungs, and the esophagus. Endoscopic screening of the upper gastrointestinal tract allows for timely detection of second primary tumors in early and curable stages. Early stage second primary tumors in the esophagus can be treated with endoscopic resection and thereby may potentially improve the survival of patients with head and neck cancer. Data from screening studies originating from Western countries are scarce and mainly consist of studies with small numbers of patients with head and neck cancer. Currently, in most Western countries, screening for second primary tumors in patients with head and neck cancer is not widely implemented. Therefore, we performed a single-center screening study in a tertiary referral center in the Netherlands. Patients with head and neck squamous cell carcinoma located in the oropharynx without association with human papillomavirus, hypopharynx, and other head and neck cancer locations in combination with alcohol abuse were included. All included patients received treatment with curative intent and routine follow-up for head and neck cancer. Endoscopic screening included precise inspection of the esophagus with white light imaging, narrow band imaging, and Lugol staining. Second primary tumors were defined as the presence of high-grade dysplasia or esophageal squamous cell carcinoma. In total, we included 202 patients with head and neck cancer and performed 250 screening endoscopies. We detected 11 second primary tumors in 10 patients with head and neck cancer. So 5% of the patients with head and neck cancer was diagnosed with a second primary tumor. 90% of the patients with second primary tumors were diagnosed with a second primary tumor in early stages, and 80% of the patients could be treated with curative intent with endoscopic resection. None of these second primary tumors in screened patients were detected on routine imaging such as an MRI or PET-CT scan for head and neck cancer prior to endoscopic screening. In conclusion, in 5% of the patients with head and neck cancer in a Western country, a second primary tumor in the esophagus was detected. Therefore, we believe that endoscopic screening should be considered in the selection of patients with head and neck cancer in Western countries. We believe that this selection should include patients with highest risk for second primary tumors with an acceptable life expectancy based on their head and neck cancer prognosis and other comorbidities. Future studies should investigate the individual risk-benefit profiles of all patients with head and neck cancer treated with curative intent in Western countries. We believe that the ideal setting would be a combination of a nationwide endoscopic screening study and development of a risk prediction model, both including all patients treated curatively for head and neck cancer. Thank you for your attention.